today's talk is physical activity, sedentary behaviour and mental health during COVID-19. And this seminar series is jointly organised by Brunel's Sedentary Behaviour, Health and Disease Research Group, led by Dr. Daniel Bailey, and the Health Behaviour Change Research Group, led by myself, Dr. Emma Norris, and Dr. Kai Long Chung, all at Brunel. So today we're very lucky to have two presentations from Professor Mark Hamer from University College London and Professor Costas Karageorghis from Brunel University in London. So first I'd like to welcome our first speaker today, Professor Mark Hamer from the Institute of Sport, Exercise and Health at University College London. Mark's research focuses on physical activity and population health, especially in relation to heart disease, healthy ageing and mental well-being. He is involved with a number of world-leading cohort studies, including Whitehall 2 study, the 1970 British cohort study, and the Prospective Physical Activity Sitting and Sleep Consortium. Professor Hamer will present on the first large-scale general population study on lifestyle risk factors for COVID-19, using prospective cohort data with national registry linkage to hospitalisation. So thank you to both our speakers, and thank you first of all to Mark for your presentation. We really look forward to it. So over to you, Mark.
Thanks very much, Emma. Thank you for the invite from Dan. It's a pleasure to come and speak this morning. So as Emma mentioned, I'm going to be talking about some of our work on physical activity and community-acquired infection from some of the large epidemiological cohorts that we've been working on. So the prime question I'm going to ask this morning is, can a physically active lifestyle reduce the risk of serious outcomes from community-acquired infections? And what we're not obviously trying to investigate is whether being physically fit can stop a person from actually getting infected with a virus. But what we're more interested to know is whether once that person gets infected with a virus, if they're fitter, can they actually cope with it better? And just to put this into context, why would this be relevant to the current pandemic? Well, pre-pandemic, we know that a large proportion of the population do not meet the Chief Medical Officer physical activity guidelines, which is 150 minutes per week of moderate to vigorous physical activity. And you know, if you even lower that recommendation down to what proportion of people are active for at least 1 day a week, there's still a large proportion of people that don't meet that guideline. So these are some data from Sport England from their Active Live survey. And they were actually able to look at what was the impact of the first lockdown on physical activity. And you can see that they've got these year-on-year data, so they can make these comparisons from 2019 to 2020. And they estimated that in that first lockdown about a year ago, physical activity levels dropped by around about 7%, which may seem trivial, but in England that reflects around about 3 million fewer adults being active. So if in the backdrop of a population that is already relatively inactive, the pandemic has clearly further reduced that. So potentially this could be a recipe for disaster, with a highly contagious virus and a pretty sedentary population. So the whole area of exercise immunity is certainly not a new area. The first studies in this area probably took place around about 100 years ago, and these early studies were in animals, and they looked what happened when you infected an animal and then you got the animal to perform exhaustive exercise, and actually the animals didn't fare very well, because those that went through this exhaustive exercise protocol had much worse outcomes following the infection. And this has led researchers to look at how elite athletes fare when they're under very high training loads, what happens to their immune function. And in some athletes, when they're under high training loads, this has quite an adverse influence on their immunity and their risk of catching various infections. And so this has really led to this, what you would call this U-shaped hypothesis, where what we think is happening, if you look at the y-axis as risk of infection, and on the x-axis you've got level of physical activity. When athletes are under very high levels of intense training, they're possibly at high risk of infection. Whereas people who are not doing any exercise at all are also under a similar greater risk of infection. But actually, we don't really know very much about this in the general population, because most of the work has been done in elite athlete populations. So the aim of our work was really to explore this association between physical activity levels and community-acquired infections in general population cohorts. And some of the key advances in our approaches have been the use of some of these very large representative, large-scale data sets. We've got prospective linkage to clinical records, so we're not relying on symptoms. We've actually got clinically verified infection data and hard outcomes such as mortality, whereas many of these previous studies in athletes have actually simply relied on symptoms to define, for example, an upper respiratory tract infection. So this is a general overview of the sort of design that we use in the studies I'm going to present to you. These are prospective cohort studies. So we start off at baseline where we recruit our sample. And this is where we collect our data such as physical activity and some of the other important covariates such as smoking, body mass index, social status, etc. We then, sometime in the future, perform clinical linkage, which may consist of hospital admission data, mortality data. And what that captures is all of the events that took place between your baseline and your follow-up linkage. So I'm just going to start firstly talking about the study that we did pre-COVID using Health Survey for England and the Scottish Health Survey. These are both household-based surveillance surveys. We would say these are our best representative studies that we have in the UK because of this multi-stage stratified recruitment methodology that we use. On average, obviously these surveys take place every year with a different set of participants, and you get a sort of like quite a variability in the proportion of people that actually take up the study. Although what is really good is we get a very high proportion of participants that consent to prospective linkage with mortality. So the analysis that we did with this data set was to look at associations between physical activity and risk of infectious disease mortality. Now, in the UK, by far the most common infectious disease, type of infectious disease mortality is pneumonia. And these are the basic unadjusted numbers looking at the association between physical activity and infectious disease mortality. So on the y-axis, we've got the number of events per 10,000 participants. And then what we've done on the categorization of activity, we've put people broadly into three categories: those that didn't report any moderate to vigorous physical activity, those that were insufficiently active, so people that were reporting some but not reaching the current CMO guideline, and then the active people are the people that do reach that 150-minute mark. And you can see just from the quite crude look at the data that the rates of infectious disease mortality are far lower in those people that are physically active. Now, when you dig into this a little bit deeper and to look at the sort of detailed dose response pattern, and also obviously start to adjust the models, because one of the things we're concerned about with this sort of analysis is obviously confounding. So in this analysis, we split the group into 5 categories using meta-hours per week. So that first category, less than 1.6 meta per week, is literally people who are really reporting very little activity at all. That's less than half an hour's walk a week. And that's a reference category. And you can see these are hazard ratios with confidence intervals. We can see even with some physical activity, we have quite a large reduction in risk of infectious disease mortality. That continues to go down somewhat, although really you can see with these high levels of activity, there's lots of overlap with the confidence intervals. So when I look at this, I would say that's really an L-shaped association. It's certainly not linear. So the biggest benefit is certainly moving from that inactive category to the category where people are doing some activity. And these models were adjusted for these key confounders such as age, sex, existing illness at baseline, social occupational strata, body mass index, smoking and alcohol. So just wanted to move on now to the second study that we performed, which is a similar type of study, but we actually performed this during the pandemic with COVID-19 data. And we did this study using UK Biobank. UK Biobank started back in 2010 when the team recruited over 500,000 people across 22 different research centres in the UK. This cohort is restricted to participants who were aged 40 to 69 at baseline. And you should note that the response rate was very different to what I've just shown you in Health Survey for England. The response rate was much lower, which would suggest that UK Biobank is a far less representative cohort. In terms of outcomes for this study, we used linked NHS records, which reflects COVID-19 admissions between the 16th of March to the 26th of April of 2020. So it was really in that first sort of 6 weeks, that first lockdown period that we had. And just in a similar fashion, we've just presenting this in exactly the same way as I showed you for the HSC analysis. We've got these 3 groups for physical activity: the inactive, the insufficiently active, and the active. And we've got events per 10,000. You can obviously see that the absolute number of events per 10,000 is far lower than the previous analysis, because don't forget that the previous analysis was a follow-up over 9 to 10 year period, whereas this is a follow-up. This reflects an outcome follow-up period of 6 weeks. Like the previous analysis, when we look at this in a survival model with covariate adjustment, these associations between the protective associations of physical activity with COVID-19 remain very robust. So we went on to do a further analysis, which was to calculate something called a population attributable fraction. And just to put this, to explain this in a simple fashion, the population attributable fraction really tells you that if you were to remove a certain risk factor from the population, what effect would that have on your outcome of interest? So in other words, if I were to remove smoking from the UK population, what proportion of serious COVID admissions might that prevent? So the calculation is based on two key factors. It's firstly, how prevalent is your risk factor in the population of interest? And secondly, what is the strength of the association between your exposure and your outcome? So because I mentioned that UK biobank is not hugely representative, so we have taken prevalence data from Health Survey for England, which I'm showing you here. So the current figures from HSC suggest that in England, we've got around about 17% smoking, just over 25% would be considered inactive. That's based on a 30-minute per week guideline, so quite a generous cut point there. And in terms of obesity, it's just under 30%. So those are the prevalence data that we used in the calculation, and the relative risks were generated from the previous analysis that I've just shown you. So these are the actual paths. So if we were to, so I should also say that a key assumption of this calculation is causality. So the calculation assumes that our exposure is causally driving our outcome. So that's something to bear in mind. So if we were to eliminate smoking in England, then we might expect to see to remove just under 15% of serious COVID admissions. If we were to remove all inactivity in England, we might see just under 10% reduction in admissions. But the really big one is obesity. So if we were to eliminate obesity, we may see a reduction in 30% of serious COVID admissions. And the reason that number is big is that firstly, obesity is highly prevalent in England, but secondly, there's a very strong association between obesity and COVID. So morbidly obese have over 3 times increased risk of a serious COVID-19 admission. So just the last piece of work I want to show you is actually something that's currently in press, and this was a meta-analysis that we did to look at associations between physical activity and various immune markers. One of the outcomes we looked at was infectious disease mortality, and there isn't very much data in this area, but you can see the data that we do have is all pretty consistently showing that physical activity is associated with a protective benefit in terms of reducing risk of serious infectious disease. So just to summarize our findings, habitual physical activity measured in the general population was associated with around about 30 to 40% lower risk of a severe infectious disease outcome. And that's after you account for these confounding factors when you control for these covariates. What's interesting is this association doesn't really seem to be linear. You seem to see quite a sizable reduction in risk, even at that very first part of the curve. So when someone jumps from doing 0 physical activity to doing something, we certainly didn't replicate this U-shaped association, which has been found in athletic samples. And that's probably because we are working on a general population cohort. Obviously, some of that those cohort will be into quite heavy levels of exercise, but we certainly don't replicate that U-shaped association. And just to summarise our population attributable fraction calculations, if we were to get the British population healthier in terms of their lifestyle, then that could certainly prevent a large number of these severe admissions, if indeed these associations are actually causal. Just my last slide, I just wanted to talk about the sort of biological plausibility. Is it really plausible to think that physical activity could improve our immunity to the extent of reducing very serious illness? I think there's a number of plausible mechanisms. There's been a lot of talk about COVID-19 being quite a peculiar virus in that it's seems to have been associated with the endothelial function, and if it is indeed having that sort of origin, and we know that physical activity is extremely important for cardiovascular health, it's been linked to improvements in the endothelial function and blood pressure and vascular health in general. We know there's lots of data to suggest physical activity is very beneficial for metabolic function in terms of glucose control, visceral adiposity reduction. So it may well be that physical activity is very important in mediating or moderating this link between obesity and COVID risk. And lastly, we know that physical activity is a powerful anti-inflammatory mechanism, and there has been talk about this cytokine storm or an over-inflammatory response to COVID. So it may be that physically trained individuals are better able to control this sort of mechanism once they are infected. So I'd just like to thank you for listening, and I just want to acknowledge some of my colleagues that were helped on these various analyses, David Batty, Mika Kivimaki, and Manas Stamatakis. Thank you very much.
Thank you so much, Mark. I think the one takeaway message that we can all take from that presentation is basically the biggest improvement is to go from no activity to something. So if we can all take that kind of key message away from Mark's talk, I think that's a really important one. So I think we've had a few questions to Mark, so we'll have some time now and then some time at the end for kind of overall questions and discussion as well. So the first question that we received, Mark, is why does high intensity of activity make someone more susceptible to contracting the virus? I thought that the more active you are, the more preventive the effects would be.
Yeah, so just to highlight that we didn't actually find that. So I think I referred to prior work in athletic samples that has found athletes under very high training loads do seem to be more susceptible to infections. But as I said, we didn't find that. One of the reasons for that may be that our outcome was a very hard outcome. So we were looking at, death. We were looking at hospital admission for infections. The previous data that has generated this sort of U-shaped type association has used symptom-based measures. So when these athletes are contracting infections, we're talking about them coming down with common cold, maybe flu, but it would be very, very rare for these athletes to actually be hospitalized. So I think there's a really important distinction there. This earlier work showing the U-shaped curve was really not looking at very hard outcomes, which is what we have been doing.
Thanks, Mark. So next question is, for the activity to be considered physical, does our heart rate have to be of a particular number of beats per minute, i.e. 220 minus person's age, or does the beats per minute not matter? Thank you.
Okay, yeah, thanks. That's a really good question. So obviously heart rate's very individual. It will vary with age and training status. I think what often a better guide to use in terms of how intense, the whole intensity issue is, whether you can still manage to have a conversation when you're exercising. So if you reaching that sort of like moderate form of exercise, a good guide is that you should still just about be able to have a conversation, but obviously you should be, breathing quite hard. Once you get to the point where you're not able to have the conversation with somebody, then you've probably moved into that vigorous zone. And as I mentioned, you don't need to move into the vigorous zone to get health benefits. Keeping it at that moderate level is certainly going to give you benefit. And in fact, brisk walking is probably one of the most popular forms of activity in the UK at the minute from our Health Survey for England. Yeah, so probably don't get too worried about heart rate. I would use other more subjective markers of effort.
With a question from Ruth, would these findings help explain some of the variance in mortality figures between different countries, e.g. Japan, where they have much lower rates of mortality?
Yeah, that's a really good question. And interesting, the World Obesity Federation have just released a really interesting report last week that did an analysis based on each country's prevalence of obesity, and they compared that with their number of deaths relative to their population. And what you see is there is around about a correlation of 0.5 between a country's prevalence of obesity and their death rates. So there absolutely is a very plausible and good link between obesity levels in countries and how they've fared on the COVID front.
Another question, this time from Christine. Immunity is a complex phenomena, and it's great that you looked at a range of confounders. However, is it possible that part of the association is psychological factors which draw people to exercise, and these are also linked somehow to improved immunity?
Yeah, so in observational epidemiology, residual confounding is always a big worry. We can never possibly adjust for everything we want to because we haven't measured it. I think it's absolutely plausible that there are unmeasured confounders that we haven't accounted for that could partly explain some of the associations. I haven't seen. We know that mental health has probably suffered during lockdown. I'm not aware of any really convincing evidence that has suggested a link between mental health and serious risk of serious COVID admissions. But I may well be wrong, and I may ask Costas to pick that up if he knows of any data. But I think it's very plausible suggestion.
And another question, so given that physical inactivity is higher in ethnic minority groups in the UK, did you explore this in your studies?
Yeah, so in Health Survey for England, we have previously shown that participants from with South Asian backgrounds, so Bangladesh, Pakistan, India, tend to report much lower levels of physical activity. So that would be an obvious confounder in our associations. And ethnicity is something that we adjust for in our analyses, particularly in the UK Biobank analyses, because we have pretty good data on ethnicity. Having said that, in these cohort studies I presented, 95% of the cohort is actually white British. So we don't have huge options. We don't have a huge level of statistical power to actually examine that question. But obviously ethnicity is a really crucial factor in COVID for sure.
It's actually a related question, which is the last one that was asked. So could you explain what you mean when you say hate to see data is more representative than biobank? So I guess, yeah.
Yeah, sure. So HSC has a very particular method of recruiting participants in the study, which is designed to in essence, it's a random postcode kind of lottery. So they try to pick up people randomly across the entire country. This is quite different from the UK Biobank approach. And the main problem with UK Biobank is, although they sent out random invitations, only 5% of those invitations that were sent actually got picked up. So if you look at the basic characteristics of UK Biobank, compared to the general population, it contains people who are probably from higher social strata. They are a bit healthier than what we would normally expect from that age group. So that's why we would say that UK Biobank is not considered to be particularly representative of the English population, compared to something like Healths Over England, which is not perfect, but it's quite a bit better.
Thanks, Mark. And just one more question before we move on to Costas's presentation from Maria. Since obesity is the biggest risk factor that is strongly associated with COVID-19, is there any data of how much obesity has increased since March 2020? Should advice about being more physically active be shared with GP practices and with people who are considered obese by BMI standards?
Yeah, I mean, that's an excellent question, and I completely agree. You know, I think this has been recognised. I think the Prime Minister recognised this, and he released, or he's supposed to have released some money for focused research on this area. You know, if you look at the data, I think you'll find that some people have put on weight, whereas other people haven't. They've fared better. So I think it's quite a complicated. The data are probably quite more complex than they seem. It's not simply a case of everyone has put on weight. But obviously, I think there has been a potential to put on weight. We've all been stuck at home. If I think about my own kind of lifestyle, that incidental activity has all gone because, I'm not walking to meeting rooms anymore. I'm not more walking around campus. You kind of get up, go to your desk. I may get out and do some very structured exercise, but I think what we've missed is all of that sort of incidental movement. So yeah, I think obesity is an absolutely crucial issue in this whole pandemic.
Thanks so much, Mark, and a really great presentation. So we'll pick up on some more general questions between the two speakers at the end. So now I'd like to move on to our second speaker, Professor Costas Karageorghis, from the Division of Sport, Health and Exercise Sciences at Brunel University, London. So Costas is Divisional Lead for Sport, Health and Exercise Sciences at Brunel. He's internationally known for his research into the psychological, psychophysiological and neurophysiological effects of audiovisual stimuli in exercise and sport. Costas will present on the effects of COVID-19 lockdown on physical activity, sedentary behaviour and mental health across 4 Western nations: USA, UK, France and Australia. So we're really looking forward to a presentation, Costas, and thank you again.
Emma and Dan, I'd like to thank you very much indeed for your kind invitation. I was delighted to be preceded by Professor Mark Hamer. Professor Hamer was actually a student of mine, believe it or not. I know I look quite fresh-faced, but more than 20 years ago. I remember him as a young triathlete wearing quite garish all-in-one sort of lycra bodysuits. He was sort of a slightly less ostentatious version of Mr. Motivator. So yes, a great pleasure to follow, Mark, and it's interesting how our paths have crossed over the last 20 years in various projects. As Emma mentioned, my main area of research has to do with audio-visual aids in the physical activity sphere. But about a year ago, almost to the day, I had 3 experiments in train, and the physiology technician at Brunel burst into my office while I was in the middle of a tutorial and said, Costas, all of the experiments, they have to stop at once. You need to get all of the students out, shut everything down. And of course, that put paid to all of the work that I had in train at that time. And in the days that followed, I had to really refocus and think what I would do during this, this health crisis. COVID-19 has been the defining issue of our generation. And so what I did do, in fact, was that I made contact with many of my colleagues around the world, with whom I had collaborated over many years in the music and audiovisual aids sphere. And I asked whether they might be interested in doing a study around physical activity, sedentary behavior, and mental health during the pandemic. Very early in my career, I did have an interest in psychometrics and physical activity. I worked with Peter Terry, Andrew Lane, Simeon Vlahoboulos in the sort of mid to late 90s. So I had a little bit of a taste for that sort of work back then, but mainly working with people whose forte that was. So in the UK, I collaborated with Dr. Jonathan Bird at Exeter, a former doctoral student of mine. And of course, I've already mentioned Mark, with whom I've collaborated for many years on a variety of projects, and he's a very fine colleague. There's a group that I've been working with at Springfield College in the USA. They're probably in the land of Nod right now. 2 colleagues at the University of Lille in France, Professor Yvonne Delavoye-Terrell and Ségolène Guérin. And of course from Australia, Peter Terry, with whom I've worked in the music sphere over 3 decades now, and Renee Parsons-Smith and Victoria Terry. So I think it's worth just acknowledging the assistance and guidance I've had from my co-workers in relation to the work that I'm going to present. I did try to get a group from Brazil as well to collaborate in this study, but things were really going off there in terms of COVID, and I didn't manage to get the Brazilians, but I was happy to get samples from the UK, USA, France, and Australia. So in terms of some background to this particular multi-nation study, clearly, as Mark alluded to earlier, lockdowns by their very nature reduce opportunities for physical activity. So that is a given. And they encourage greater sedentary behavior, such as sitting, playing video games, watching TV, Netflix. I know a lot of my students were immersed in, against what we have learned is an existing backdrop of very high levels of sedentary behavior in developed nations. I was reading a paper just this morning, published in BMC Public Health, which stated that obesity has caused more deaths in England and Scotland since 2014 than smoking. So I think that follows on very well from some of the data that was presented by Mark earlier. So of course, a concomitance of sedentariness is compromised mental health. And a very interesting study by Mark and his colleagues in BMJ Open looked at associations between objectively assessed and self-reported sedentary time with mental health in adults. Mark et al.'s sample was drawn from the 2008 Health Survey for England. They used the 12-item general health questionnaire, which is actually one of the instruments that we used in the study that I'm presenting today. They had over 11,000 participants who self-reported their sedentary time, and around 2,000 from whom they collected objective data by use of accelerometers. Now, the highest tertile, the highest third in terms of objective and subjective sedentary time, were associated with higher risk of psychological distress in accord with the general health questionnaire. So, you know, that was interesting and provides part of the background for this study. But in terms of my own mental health and my own anxiety, some of the aspects that really got me going was just seeing the physical damage that people were suffering at the hands of COVID. What I've presented to you here on the left-hand side is a healthy heart versus on the right-hand side, the heart of a COVID-19 patient. And what you can see on the right-hand side is the splintering of blood vessels. It's quite an extreme example here, that of course makes oxygenation so difficult and lies at the heart of the problem, if you pardon the pun. If we also look at the image here of healthy lungs versus the lungs of a COVID-19 patient, again, a very stark and worrying difference. The infection causes alveolar damage, capillary congestion, necrosis of pneumocytes, interstitial and alveolar edema, that is fluid in air spaces. Of course, the lungs can't function as they should. We can't breathe properly. We can't absorb oxygen into the bloodstream. We experience hypoxia, and it leaves patients needing ventilators. We saw this with our local MP, of course, the member for Uxbridge and South Ruislip, the Right Honourable Boris Johnson, who was admitted to St Thomas's Hospital, and made many of these issues, the sort of mechanical issues, he served to make them very public. So continuing with the background to the present study, sedentary behaviour is associated, as we've learned, with greater risk for all-cause mortality, that is death from any cause, cardiovascular disease, type 2 diabetes, diabesity, which is a combination of type 2 diabetes and obesity, and of course some cancers. And early COVID findings that I was seeing in May, June showed sharp reductions in physical activity, even among people who were habitually active. Increases in sedentary behaviour, particularly sitting and screen time, decrements in mental health, and the effects of the pandemic on mental health were particularly acute among women. So this is a theme that we'll pick up again later. Now, such changes in key health outcomes are probably not evenly distributed within populations and across nations, and this provided a rationale for the purpose of the study. You can see here the sort of public messaging. This is an exercises medicine infographic that were common in the UK, encouraging people to move more. And we'll pick up this theme again in a short while. I just want to touch on some international data from Tyson et al. That's not Iron Mike, by the way, on daily step counts across the world. On the left-hand side, we can see American cities, and on the right-hand side, we can see international cities. And what is stark within these data is a very sharp decrement when regional orders were placed, such as lockdowns, in terms of daily step count. There were decrements in the order of 2,000 to 2,500 steps per day. In cities, if you look on the right-hand side, top right, such as Seoul, Tokyo, Stockholm, where there were not such strict restrictions or no restrictions at all, you can see people's physical activity levels in terms of daily step count being well maintained. So this is the backdrop against which we were working. The primary aim of this study was to examine the perceived effects, although we did have some objective data as well in the form of step counts, of the initial COVID-19 lockdowns across 4 Western nations, the nations I mentioned earlier, the UK, USA, Australia, France, with a specific focus on physical activity, sedentary behaviour, and mental health. We've already had an excellent introduction to these from Mark. A secondary aim was to look at some key moderators, such as age, which was the main moderator that we looked at in terms of age groups, but also we looked at sex as a moderator with a specific focus on mental health. So we collected a lot of data in this study, and I just want to be very clear. I'm going to present just a portion of the data today, but there are other studies, nation-specific, that have emanated from the data collection that took place during the spring and summer of 2020 across the 4 nations. So, first hypothesis, we expected reductions in planned and unplanned dimensions of physical activity, N steps per day, from pre to during lockdown, and we thought at the time that this decrement in physical activity would not be moderated by age. We also expected increases in sedentary behaviour from pre to during lockdown, again with no age moderation. And we expected a decline across the board from pre to during lockdown in mental health, but a greater decline among women, predicated on data that we were looking at a year ago or just under a year ago. So that means a significant lockdown by sex interaction. Now, we did include nation in our analysis. This was a descriptive study that looked across 4 nations, but that was purely explored, and we didn't have any a priori hypotheses in relation to nation. So in terms of methods, our study was approved by the Brunel Research Ethics Committee, but also by each of the individual local ethics committees in each nation. We made some sort of cultural tweaks. We ensured that each of the surveys was culturally specific, using a lexicon that was specific to each nation, and using demographic factors such as socioeconomic status specific to each nation. So I want to make it clear that we cannot infer causation from the findings I'm going to present today. This is a cross-sectional study, and in terms of perceptions of behaviours and mental state pre-lockdown, we employed a retrospective frame. So many of the researchers listening in will be aware of the error variance that is germane to the use of retrospective frames in research of this nature. In terms of eligibility criteria, we only sampled from adults residing in the 4 target nations, and they needed to speak the main language of their country of residence. We translated the suite of instruments into French for the French study. In total, we managed to get around 2,500 responses, which we thought was pretty good. This is in the strict period of lockdown, and you can see the nation breakdown. A limitation which I'll touch on again later, you get this self-selection bias when you conduct survey type research, and we had many more women respond to our call, thank you women, relative to men. So around 2,000 women responded and around 600 men. And you can see at the bottom of the slide there some of the e-leaflets that we put out on a variety of social media channels in order to recruit. Okay, so in terms of the measures, I want to highlight that we did think about exercise motives as a relevant predictor. In the data I'm going to present today, I'm not going to mention exercise motives, which we measured using Markland and Tobin's behavioural regulations in exercise questionnaire 3, which many of you will know is predicated on self-determination theory. We did use an instrument predicated on the theory of planned behaviour by Ajahn, an instrument we developed here at Brunel 16 years ago. We published it in the British Journal of Sports Medicine, the Brunel Lifestyle Physical Activity Questionnaire, which taps planned and unplanned dimensions of physical activity. So, you know, we were interested in this distinction. We were mindful of the fact that many people's planned schedules of physical activity would be interrupted by lockdown, but we wondered what the ramifications would be for unplanned or lifestyle physical activity. Measures of sedentary behaviour, I'd say, were fairly crude in this study. We actually pulled the study together and got ethical clearance very, very quickly in the matter of 2 or 3 weeks. So we got estimates of daily sitting and screen time in hours. And as I mentioned earlier, we assessed general health using the General Health Questionnaire 12. Those of you who are familiar with this instrument, it's a 4-point scale, a Likert type scale, and it taps depression, anxiety, and social dysfunction. In terms of data analysis, we did a very thorough screening of univariate and multivariate outliers. We examined the various assumptions that underlie mixed model MANOVA, which was our test of choice, and we used a 2 by 4 series of ANOVAs and MANOVAs. But with the General Health Questionnaire data, we used a 2 by 4 by 2 ANOVA, lockdown by nation, by sex. So looking at the results now, I said that we were very thorough in terms of data screening and diagnostics. In our screening, we identified 200 univariate outliers, which we modified slightly to bring them in the range of -3.29 to +3.29 in terms of standardized or Z scores. We also identified 44 multivariate outliers. So these are cases with an unusual pattern of scores. So in this instance, we took care to only screen out those multivariate outliers in the multivariate analysis to which they pertained. So they were not deleted altogether. They were only screened out in the analyses to which they pertained. Except for 3 cells that exhibited moderate negative skewness and 13 that exhibited moderate positive skewness, we were fortunate in that we found normal distributions in the remaining 160 cells of the analysis. So more than 90 cells in the analysis exhibited a normal or Napoleon's hat type distribution. You can see a normal distribution at the bottom of this slide there. Also, as part of our screening, we looked at Box's M-test for equality of multiple variance, covariance matrices. All right. So it's time now to have a look at some of the data. So this is a stacked dot plot. If you're not familiar with this type of data visualization, it's fantastic insofar it allows us to present a large amount of information that the reader can pick up at a glance. You can see all 3 factors of our analysis in terms of pre to during lockdown, the nations and the various age groups. You can see where differences lie. They're marked by brackets. You can see 95% intervals. So with 95% intervals, that doesn't mean that they cover 95% of the data, but we're 95% certain that the mean of the distribution is contained within those. So what we've done here is, for each age group, the darker plot is the during lockdown and the lighter plot is the pre-lockdown. You can see quite marked changes to begin with, just across nations. There was in fact a main effective nation, and we did relatively well in the UK in terms of maintaining our planned levels of physical activity. Also, you will see that the planned physical activity levels of older adults above 60 years of age was fairly stable, other than in the USA. But the thing that is slightly concerning about these data, if you look at the blue plots on the extreme left and the extreme right in the USA and Australia, you see a very sharp decrement in planned physical activity among young adults. And this is a theme that we will pick up again later. We conducted a very similar analysis for unplanned physical activity. So this is activity that isn't scheduled, and there's an even more dramatic drop that is evident across nations in terms of decrements in unplanned, unscheduled physical activity for young adults. So if you have a look at the blue plots to the left-hand side of each nation, that comes across quite starkly. Again, relative stability for the older adults. This is a little bit of a recurring theme in these data. So now we move to a rain cloud type plot. This allows us to look at the 95% confidence intervals to gauge differences, and we set those in apposition to histograms. What we've done is we've set the pre-lockdown distributions in pink and the during lockdown in green. You can see there that in terms of the interaction that is plotted, it's a two-way interaction of lockdown by nation for steps, that we get a significant lockdown by nation interaction because it's driven by a very sharp decrement in steps per day in France. Note that there was a main effect of lockdown in terms of steps. So across the board, there was a decline in steps, similar to the international data that I showed you earlier. And if we switch to the rain cloud plot for lockdown by age group, we see a sort of convergence as we go down the age groups. There's a very stark difference in the steps per day from pre to during lockdown for young adults. The difference is less marked as we progress through the age groups. So the older adults above the age of 60 years were better able to maintain their physical activity in terms of steps per day, this more objective marker. Here we move on to sedentary behaviour. This is a lockdown by nation, a two-way significant interaction. Now you can see that across the board in terms of sitting and screen time, there were marked rises in sedentary behaviour. But in some nations, such as the USA, for example, if you have a look at sitting time in the USA, you get a very, very sharp increase in sitting time in the USA versus, for example, in the UK. Or if we compare screen time between the USA and the UK, we can see again that there is a marked difference. Let's now move on to the two-way interaction of lockdown by age group for sedentary behaviour. We can see that pattern of sort of convergence as we come up in the age groups. There is a very stark difference in the young adults age group huge difference from pre to during lockdown in both sitting and screen time. But if we look at the older adults, again, although there is a significant difference when we look at the confidence intervals, we can see that it is a less stark difference. And here we look at a two-way interaction of lockdown by nation for the mental health scores. Now, I just want to make it clear that higher scores on this particular instrument are indicative of compromised mental health. So there's a significant lockdown by nation interaction. It's a relatively small effect, but it's significant. And what we can see is that there is a very sharp decrement in perceived mental health from pre to during lockdown in the USA. The difference was least marked in France. These particular data reveal least marked in France. And now we look at the interaction of lockdown by sex for GHQ 12 scores. And what this is showing us, there was a main effect. There was, of course, a decrement in mental health across the board. But the way that women are perceiving lockdown seems to be causing a greater decrement in their mental health when compared to men. It may be having to work at home, having to homeschool, caring responsibilities, taking maybe a larger proportion of domestic responsibilities is having a detrimental effect on women's mental health. And this is something that we need to pay very careful attention to. This is a little Brucey bonus. This is not part of the data, the international data that I've been presenting today, but just to finish, this highlights and shines a spotlight on UK data. This is using the exercise motives as a covariate, and we see sharp decrements in planned and unplanned physical activity from pre to during lockdown, top left. We see a decrement in steps per day of around 2,000. And if we look at the bottom there, we can see increases in sedentary behavior, sitting and screen time, with these being most marked among young adults. So this is an important and recurring theme in these data. So moving on to our discussion. What is clear is that planned and unplanned physical activity, as well as steps per day, declines significantly. But there was an age moderation, actually, so H1 is only partially accepted. The lockdown by age interaction that emerged for unplanned is attributed to a steep decline among young adults, as I mentioned earlier. Interestingly, the decline is least pronounced in the UK, so we did relatively well with our messaging in the UK. Across all nations, there was a decline in step count of around 2,000. So in calorific terms, that's around 100 kilocalories, or around the equivalent of maybe walking a mile a day. There was an increase in sedentary behavior and a lockdown by age group interaction for sitting and screen time. So given the moderation of age group, the second hypothesis was not accepted. There was a strong moderation of age group, as we saw in particular with the younger and older participants. And we did encounter this lockdown by sex interaction. So we accept the third hypothesis. The largest decline in mental health was in the US sample, and the smallest was in the French sample, as we saw in the visualization. And lockdown was particularly deleterious, particularly harmful for women's mental health. This is something that we might pick up in our discussion. So in terms of strengths and limitations, we've got strengths at the top here and limitations at the bottom, we did make cultural adjustments for each sample, and we were quite nimble. We moved quickly to capture the data during the initial period of strict lockdown across the 4 nations. Given that our survey took around 20 minutes, maybe 25 minutes for some to complete, and that we didn't offer any incentive for completion, the sample size was relatively good. Now, the limitations. I mentioned about the self-selection bias that pervades cross-sectional work of this nature. We clearly had an overrepresentation of women. Perhaps if we had in-person administration of surveys, we'd been able to recruit more men, but that wasn't possible under the restrictions. We had a severe underrepresentation of ethnic minorities. Fewer than 10% of our respondents represented ethnic minorities, people of color, and also lower socioeconomic groups were highly unrepresented in our data, particularly in the French data. Remember the problems of retrospective recall. For all of you young researchers, you're going to get a greater error variance with retrospective recall of things like physical activity, sedentary behavior, and mental health. But interestingly, the pandemic created conditions for what we call a natural experiment. And in our group, we had to abandon existing research we had ongoing and take advantage of that natural experiment. But I want to make it very clear that we cannot infer causality from the present design. We can talk about associations, but we cannot be sure about causality. I think that needs to be made very clear. So, in conclusion, lockdowns are associated with very negative consequences for physical activity, sedentary behavior, and mental health the world over. It might also be that decrements in mental health prevent people from being physically active. That might be a topic for discussion later. The present findings provide particular concern in terms of the physical activity and sedentary behavior of young adults. Hopefully, I've illustrated today what sharp decrements there were in physical activity and what sharp increases there were in sedentary behavior in this group. Relatively stable for older adults, but marked increases in young adults. And women's mental health was harmed more than men's by lockdown. We might tease out the reasons for that later. So, what should future studies do? They might provide incentives for hard-to-reach populations. We just didn't have time to apply for funding and to provide incentives to our participants. So that is something we might do in the future. Simply encouraging people to walk an extra mile a day would overcome those decrements in steps per day that we saw. So 2,000 steps are roughly equivalent to walking a mile. So that very simple messaging to the public could have a significant effect. I think that intervention should be targeted specifically at young adults and using media that are popular with young adults, such as TikTok and Instagram. Now I'm going to stick my neck out here. We heard Japan mentioned earlier. I think it was Ruth who mentioned the lower levels of mortality in Japan during this crisis. Well, what do they do in Japan? They have designated time slots for physical activity. So in many large companies, people down tools at a certain time in the day, and they all engage in physical activity, just like the chap I've got in the image here. During times of lockdown and national crisis, should we consider a national time slot for physical activity? When I was a young boy, mid-morning every day at school, we'd have this movement to music, and music piped over the speakers from BBC Radio, and we'd all move in time to the music. We'd all be physically active. Do we need something similar at population level? So that is my parting thought. Thank you very much for listening.
Thank you very much, Costas, for a really interesting, unique and really comprehensive study there of those 4 countries in particular. I'd like to start with some comments and questions that have just come in on the chat, just to make sure we don't miss those. And Ruth has asked a really important question, which is, did the lockdown rules vary much between countries that might have made it harder to make comparisons in the study? And she also reflects that walking in the USA is much harder than in other countries. So yeah, Costas, what are your thoughts on that?
Yes, I have a couple of thoughts on that. Indeed, there's less of a culture of walking in the USA. I studied in the USA for a while, and there was a culture of going to the Y. That is how people generally got their physical activity. It was very institution-based, at least at that time. That was many years ago. And we had certain phenomena in some of the countries. So, for example, many of the French participants were recruited in Paris, where a very strict lockdown was imposed and people couldn't even go out for a walk. So there were indeed differences across nations. And as I've mentioned again and again during the course of today's presentation, this is cross-sectional data. It's descriptive. It shines a light on some of the differences across nations. You saw from some of the earlier data that some of the nations in the Far East were hardly afflicted by this crisis, but it had quite deleterious effects on some of the Western nations, such as France, such as the USA. And this is borne out not only in the data that I presented today, but across hundreds of studies that I have read in recent months, including work that's been done by Mark and his group at University College London.
Thanks, Costas. And some other comments and kind of questions in the chat as well, mostly relating to demographics of the sample, which is kind of what you're alluding to as well, that we would definitely want to pick up now. So particularly, so Ruth's comment about, it'd be interesting to see women by age group, for example. So what are your kind of thoughts and reflections, I guess, on the gender composition of your sample and the findings that you've got specifically around gender? I think to start with, that would be really useful to discuss, because I'm also thinking why in the first place you received more female responders. Is that something that you might have reflected on and thought about, and your thoughts also on the findings for gender?
Yeah, so the issues around gender are something that Mark and I and our colleagues around the world have been reflecting upon a great deal. Women generally were incredibly helpful and forthcoming in terms of responding to our questionnaire. Women in general seem to be very generous with their interactions on social media and picking up the sort of messaging that we were putting out in relation to the study. Men less so. It seems that men sometimes require more badgering to participate in a study of this nature. So just to make it clear that women were incredibly generous in giving up their time to participate in the study. Now, from a statistical standpoint, once you start looking at interaction effects and you have such a gender imbalance as we did with the recruitment in this international study, it makes it very difficult to look at, for example, lockdown by gender interactions. Okay, it creates imbalances in the cells of the analysis and also in the way that data are distributed within cells of each analysis. So from a purely statistical perspective, that is problematic in terms of generalization. So if I were to do the study again, and just remember, this thing happened suddenly. I had to abandon experiments and try and find an outlet for my desire to conduct research. If I were to do it again, I would get funding and I would ensure that there was some stratification in the sampling so that I would have equal numbers of women and men. But even more importantly still, personally, I was very interested in how the lockdown afflicted different sections of our community. I grew up in a very poor but colourful enclave of South London, and among the people that I knew from my childhood, I noticed that the lockdown wreaked devastation in terms of people being hospitalized and unfortunately even losing their lives. So I had an intrinsic interest in teasing out what those differences were across socioeconomic groups. But in this type of sampling and doing it quickly and without resource, I could not tap those groups, and I'm deeply frustrated about that. Thankfully, other groups with funding have been able to, and their findings really bear out what I suspected from the outset, which is that in terms of physical activity, sedentary behavior, and mental health, this pandemic has had a sharply disproportionate effect on people from ethnic minorities and people in the lowest echelons of society. So many of our interventions going forward should be targeted at those groups.
Yeah, I think, and there's lots of kind of congratulations in the chat as well for pulling something so comprehensive together with limited resources. So I think, you know, other researchers, etc., appreciate that
I
work.
can't see the chat, but
oh yeah.
But thank you for any comments. Thank you.
And there's been a few more kind of additional questions around well, women specifically. So I'll go to one first from Maria. Women's mental health and physical activity declined due to COVID-19 compared to men. Can this be explained by hormonal changes more prominent in female physiology compared to male physiology? An idea for a future study, perhaps.
In the present data, the data that I presented, the declines that were evident were more in the realm of mental health, not so much in the realm of physical activity. In fact, in some instances, and I've looked at some Swiss and French data, women from quite an affluent background, a middle-class background, saw their physical activity levels even rise slightly because they had more time available, not having to make the daily commute, and were thus able to exercise. So hormonal issues, which was the thrust of the question. What we noticed in women in particular was this decline in mental health. And there could be this reverse causality wherein declines in mental health and the increases in responsibility and the inhibitions that are perceived by women are perhaps impacting on their physical activity levels. I want to go back to what I said earlier about women from deprived backgrounds, women from certain ethnic minorities, maybe in patriarchal societies, in some religious groups. It may be very difficult for some of those women to be seen to be physically active in the home. And so I think beyond the hormonal and the mental health, there are certain cultural barriers that I know some of my colleagues, Professor Louise Mansfield, for example, have been very active in investigating. And so I've been sensitized to these barriers. These data do not tease out these barriers, but I'm nonetheless very mindful of them, Emma.
Thanks, Costas. And I think what you've just said picks up on Christine's question already. So I think rather than going back to that, we'll skip to a slightly different question at the moment. 10 minutes left. From Shah. Did this study account for physical activity in regards to season? So during winters in France and the UK, I'm guessing there's a reduction in steps per day, whereas in Australia it would be the opposite.
That is an excellent, incisive and insightful question. Thank you very much indeed. Given where we were with this study and the haste with which we had to bring it together, we didn't have an opportunity to account for season, and you're quite right to raise that as a potential limitation. I've done other research. For example, I've done research on music interventions with older adults in physiotherapy rehabilitation. And I know from that body of work that rehabilitation programs that are set during the summer month have higher attendance and adherence than those set in the winter months. So this is a salient factor, and I thank you very much for bringing it to the fore.
I think at this point, Mark, would you be happy to rejoin, and we'll do some more kind of collective questions just to close? One question that I'd observed earlier that I thought would be good to get both of your thoughts on was from Siana. Did your studies look at the effects of physical activity on long COVID? And if not, just your general reflections on the effects of physical activity on long COVID would be good to hear.
We did assess COVID status in our series of studies, both within each nation and across nation. At the time that we conducted our research, long COVID was not a phenomenon that we were aware of. And this is a term that has only recently entered the public lexicon. So I wonder whether from his more epidemiological perspective, Mark has some data upon which to draw and with which he can comment.
Yeah, unfortunately not. As you said, Costas, it's quite a new thing that's cropped up, and you know, a large amount of funding has literally just been released to start to look at long COVID. So I don't think we actually have any particularly good data even at the moment on it. I just, from a perspective of UCLH, I have colleagues at UCLH with long COVID patients, really struggling to know what is the best intervention with some of these patients, because even thinking about physical activity, many of these patients are literally struggling to get out of their house physically get out of their house and walk, 500 meters. So I think it's very early days for long COVID, and I don't think we do have very much data at all.
And another question, so described as a bit more of a general question for you both. So what are your thoughts on ways to improve representation in cohorts?
Yeah, I can speak to that briefly to begin with, Emma. As I mentioned earlier, we didn't have an opportunity to win funding to do the research relating to this international perspective during the strict lockdown. But had we known how long the crisis would actually last for, and the fact that there would be a second and third lockdown, we would have applied for funding in order to incentivize the participation of those hard to reach groups. In fact, we would have been able to incentivize all participants. The way that we approached it, I realize now, was not optimal in terms of democratizing the process, and that is something I would seek to do in future.
And I just comment on how we deal with this in a sort of very large scale cohort studies. The bottom line is it's a massive problem. We know that the people that don't take part or decline our invitation to take part are always from lower socioeconomic groups. They also are less healthy. They're more likely to have existing disease. Obviously, you can't force people to participate. What you can do though is to use certain statistical techniques to get around that. So you can use, not wanting to go into too much complexity, you can use things such as weightings. You can use imputation techniques. And these techniques, although not perfect, they are designed to try to get around these sorts of selection biases.
Thank you both. And just for the final question, Chair's honour, I'd like to ask for you both, is basically just to give your final takeaway thought, I guess, or takeaway comment that all of our attendees can take with them and share to their friends and family about, the kind of overall relationship between physical activity and COVID from your perspectives and your research.
From the full breadth of work that we've done, it would suggest that physical activity has a role to play as a prophylactic in this pandemic. It prevents the onset of obesity, sedentariness, inactivity, diabetes. It also serves to prevent the onset of depression, and anxiety. Even if we can exercise in pairs at a social distance, it might counter to some degree social dysfunction. So my message would be that any type of habitual physical activity during this pandemic is positive, and as exercise and physical activity professionals, we should be keeping our messaging as simple as possible. So my message is walk a mile a day.
Yeah, and I absolutely agree with Costas. I think the clear message here is anything is better than nothing. Our data certainly support that. And one final point from me is that, you know, thinking ahead in future years, it's very likely we're going to have further pandemics. And I think in terms of prevention and public health policies, we have to think very carefully about the health of our population in the UK. You know, if we'd have had a more physically active, less with lower prevalence of obesity, who knows, we may have fared much better. So I think there needs to be a real push on that.
Thank you both for those concluding comments. So just like to thank you again both so much for your presentations today, and there's lots of thank yous in the chat as well. So thank you all so much for joining, and thank you very much again to Costas and Mark for their time today, and we hope to see you again soon.